Welcome to the PsychopharmaStahlogy Show, a special NEI Podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another edition of the PsychopharmaStahlogy Podcast, featuring the one and only Stephen Stahl. Steve, how are you doing today?
Just great. How are you?
I'm really excited about this one because we're going to be talking about something a little controversial. We're going to kind of put the stick in somebody's eye here a little bit. And who better to stir the pot than our friend Roger McIntyre? Roger, how you doing?
Great to be with you. And look, I'm always open to stirring pots as long as it moves us all in the right direction. And hopefully that's what's going to move us.
Well said. Well, I think good science, is to have hypotheses and to question things. And of course, today this is in our series of psychedelics. We actually usually do three-part series here at the PsychopharmaStahlogy Podcast, but this one was so important and interesting, we've expanded into a four-part series. And so this is actually the second of our four parts. And what we're going to be doing is really focusing today on a little bit of neurobiology and how do we actually think these darn things work anyway? So there has been a lot of work in this area, and unfortunately it crosses over from science into what I would say is almost religion. There's kind of these faith-based belief systems around how these drugs work. And Steve and I in our introductory podcast kind of scratched the surface of this a little bit. But Roger, let's start out with a kind of a big picture and then zoom in a little bit. What are some of these reported mental health benefits of the psychedelic treatments?
Yeah, absolutely. And it's a great place to start the conversation because I think that we are really in a new frontier. And we now have treatments that are not just your usual sort of serotonergic drugs, so to speak, serotonin reuptake inhibitors. And the frontier is not just different, but, it seems like it could be better. And that's exciting, and that's hopeful and long overdue. Psychedelics, as you probably covered in previous discussions, yourself and Steve, is really it's a category that has a fairly broad definition. I think we typically are talking about serotonergic psychedelics, going back to the early days of course, LSD, and then of course psilocybin being the well-known serotonergic psychedelics. And I think if I was to summarize the answer in a nutshell, what I would say is where we've seen the greatest advance with the serotonergic psychedelics in general, at least from randomized, adequately controlled studies, is in adults who live with major depressive disorder and its cousin, adults who live with treatment-resistant depression. Separately, we, as you know, Andy, we have replicated phase 3 data with the so-called entactogen or empathogen MDMA for treating post-traumatic stress disorder, and that's a separate conversation. But typically we talk about psychedelics, we're typically talking about serotonergic psychedelics. Other areas, Andy, as you know, are being looked at substance use, tobacco use disorder, other conditions, including not limited to eating disorders, certainly anxiety disorders broadly. And the list goes on, but certainly the major depressive disorder and TRD subpopulation are furthest along with respect to adequate and well-controlled studies.
Do we run the risk here, though, of kind of being too good to be true? We're almost talking about treating
psychiatric penicillin.
Exactly.
Psychiatric penicillin.
I mean, we're talking about a large chunk of the DSM here, Roger.
Yeah. Look, I think that the field has really landed on where the data have been forever, that being that psychiatry is composed of syndromes that are really, and these syndromes are made up of psychopathological domains that are transdiagnostic. And clinicians know, who are joining us, that medications in psychiatry are not, specific to any particular psychiatric disorder. They really treat symptoms and dimensions of pathology. So my first reaction is that when we have a new treatment that targets the brain in regions that we now know are relevant with respect to originating symptoms, then I think all cards are on deck, possibilities are on deck. In other words, this could apply in many conditions right across the developmental trajectory. But I think we cannot be ahistorical. In other words, we do know that despite our aspiration, despite our hope, as penicillin for psychiatry, it's not typically how it works.
Right.
And we know that mental disorders are, yes, similar in psychopathology, but they're not the same. And so I would not surmise or hypothesize that they're going to be good for everything.
Right.
Although right now that seems to be some of the vibe that's out there right now.
Is there a unifying either set of symptoms or single symptom that cuts across all those things that makes it make more sense? To say instead it works for everything in psychiatry, to say it works for such and such symptom profile in depression, bipolar, unipolar, treatment-resistant, substance abuse, eating disorders, PTSD. Is there a symptom that seems to shine out there that really these psychedelics hit hardest and best?
I think it's such a great question. I think if I was to embrace the sort of the RDoC nomenclature and that framework, where we all, just for everyone, just to kind of level set again on this, our colleagues joining us. So the RDoC is authored by the NIH. It's meant to be a matrix to look at the symptoms of psychiatric disorders. I always refer to it as kind of a prism. If you put all psychiatric disorders through a prism, how does the colors spread out? And simply put, you can reduce all psychiatric disorders to a relatively finite number of domains or dimensions of psychopathology. And every clinician knows this. Fear, problems with cognition, social in general, problems with anhedonia and motivation, problems with your circadian rhythms and some of your internal sensory motor functions. And I would say for me, if I was to step back and say, okay, just to your point, Steve, where do psychedelics, where are they actually really affecting? We just recently published a paper looking at an RDoC approach to psychedelic outcomes. And I would say that, we get signal here, all these areas are looking interesting. But the one that's sort of catching my eye a bit more is the area of reward function, or deficits thereof. In other words, people who have motivational deficits, anhedonia, no joie de vivre in their life. And what's interesting, and this is where one has to sort of be a good detective on this, looking for all these pieces of circumstantial evidence. And if you go back to some of the trials that were published with psilocybin as an example, the depression outcomes on our usual metrics, MADRS and QIDS, is looking pretty interesting. But what's really more interesting is the benefit on patient-reported outcomes, quality of life, well-being, a sense of engagement in their life.
Yeah.
And again, these don't lend themselves to a simple one-size-fits-all dimension, but I sort of see that area as being especially interesting. I don't think it's less interesting, the benefit we're seeing on fear, anxiety, and of course we know this is ubiquitous in psychiatry. So I think
can I say something here? This reminds me of a conversation I had with a colleague you may know from Belgium,
Kern de Medier, yeah.
Oh, Kern de Medier, yeah.
And so we wrote a couple of papers together, and he had some, of course, several others.
Yeah.
And what he is saying, that patients don't want the same thing doctors do.
Exactly.
Right.
Doctors want to get rid of all this nasty stuff. So if you have a terrible thing that really is awful, let's get rid of it. Let's reduce it. The patients say, no. I want the positive stuff I used to have to come back.
Right.
So we want to reduce negative stuff. They want to enhance positive stuff. And it may very well be that the psychedelics are enhancing the positive stuff. Is that what you're maybe saying?
Mm-hmm.
Yeah, absolutely. In fact, there was a clinical trial. It was a randomized controlled trial with psilocybin. It was compared to escitalopram in a non-treatment resistant depressed population. And on the primary outcome, which was the QIDS-SR, both treatments improved, but there was no difference between the two groups. So it was a relatively small study. What really caught my eye, though, is the secondary outcomes.
Right.
And the secondary outcomes, I always see sort of secondary outcomes as sort of future prospects, like a college football team. And you can kind of see some future kind of potential here on those secondary outcomes. They had about 12.5 secondary outcomes, which was, I think, fair because it was exploratory and all that. What they found was that on most of these secondary outcome measures, which tapped into aspects like we're talking about, positive mental health, well-being, not just taking away my illness, but giving me a sense of purpose and a sense of function, it turned out psilocybin beat escitalopram in a lot of these measures. So again, some might say, well, that's secondary, don't read too much into it. I'm not, but I think we always keep our eyes and ears open. That just caught my eye.
Yeah, not terribly surprising. Well, Steve, it's interesting you mentioned that. Kern de Medier, of course, is published some very interesting stuff on the differences between what a provider, a physician, if you will, sees as a goal and a good outcome versus the patient. And our friend Mark Zimmerman has also published on this as well, who's another sort of curmudgeon-y, pot-stirring kind of guy. But what they both show is that we tend to be very symptom-focused, and I think we're trained. We have to use symptoms to make a diagnosis, and a lot of our rating scales, especially for registration trials, are symptom-based. But what patients care about is what you're talking about. It's quality of life, it's vitality, it's wellness, it's engagement. And I think our serotonin-based and reuptake inhibiting antidepressants don't do very well in that area, as you're talking about, and certainly not anhedonia, which is another topic, Roger, that you and I are involved with. But let's zoom in a little bit. Since we're talking about serotonin, you mentioned serotonergic, and this actually may be part of the controversy here. So let's say the classic psychedelics, as opposed to the entactogens and the dissociatives like ketamine, we have been taught that they work through agonism at a specific serotonin receptor or receptors, but principally the 5-HT2A. So tell us a little bit about that.
Yeah, this has been a well-characterized pharmacodynamic profile of, for example, psilocybin and related serotonergic psychedelics. And there are differences, as you know, Andy, between some of these serotonergic psychedelics vis-a-vis their KIs and dissociation and affinities and all that. Sure. But as a summary statement, they are 5-HT2A agonists, and there are now preliminary data to support antidepressant efficacy in non-treatment resistant and treatment resistant. We should also state that the benefits seen relatively rapidly, and it seems to be sustained, at least in the near term. Yeah. We can't say long term, we can say near term. And so the when you look at rank order, we like to rank order. We've all had these slides where we look at a drug, we rank order its affinity, and whoever's king of the hill or queen of the hill, that's the one we sort of like to look at first. And it's the king of the hill or the queen of the hill. It's the top one that binding for most of them. Again, there's differences.
Right.
And there's been a number of studies that have been done and trying to bridge this to the laboratory, looking at 5-HT2A agonism. And many people have said, well, 5-HT2 agonism also has, in of itself, beneficial effects on animal behavior that is thought to index to some extent what we're calling antidepressant effects in humans. So it all kinds of comes together. The plot thickens a little bit and gets a bit more confusing because, it'd be just wonderful if every data point was all in the direction of this thought, but it doesn't kind of work that way because when one looks at the studies now, vis-a-vis one looks at cellular and molecular studies, this is very laboratory and very scientific-y. It's turning out that the antidepressant effects, at least the antidepressant effects that we are inferring in rodents and otherwise, those antidepressant effects may not necessarily depend on the 5-HT2A. So we love brain-derived neurotrophic factor, brain fertilizer. Who doesn't want brain fertilizer? We love mTOR, the latest fertilizer we're talking about. Well, these types of fertilizers are boosted if you give some of these serotonergic psychedelics, but you don't need to bind to the 5-HT2A receptor to get that effect. We also love plasticity, neurons that fire together, wire together. And again, that effect, along with the molecular effect, may be dissociable from the 5-HT2A receptor. What is very much agreed on, though, Andy, as you know, is that the psychedelic effect, which in the rat is a head twitch, the psychedelic effect, which is a head twitch in the rat, is definitely mediated by the 5-HT2A. Right. So I think we came at this with a very reductive understanding. 5-HT2A is where the psychedelic trip happens. Right. That's where the antidepressant behavior happens. Right. But we now have to somehow reconcile a fairly rigorous and replicated finding that the, in quotes, molecular and cellular and behavioral effects that we think are in line with being antidepressant are dissociable from that psychedelic effect, which is more 5-HT2A.
So let me ask you something. Are you now convinced that all 5-HT2A agonists are not created equal? And the reason I'm saying that, of course, is that probably all 5-HT2A antagonists are more or less equal. They just block a receptor, and there's nothing very interesting about it. They're all the same. And what characterizes most 5-HT2A antagonists by their differentiation is their non-5-HT2A concomitant off-target properties. But at the 5-HT2A receptor, they're all the same. Now, pivot that to 5-HT2A agonism. And I also trying to teach that to all of our listeners. We're in a brand new era of trying to look at agonist pharmacology, and that ain't the same thing as antagonist pharmacology, whether you're talking muscarinic 1, muscarinic 4, or 5-HT2A. So, Roger, what do you think about the differentiation of different ways in which 5-HT2 agonists work to trigger? Can you have one 5-HT2 agonist effect that actually is a head twitch or hallucinations without antidepressant effects, and the other way around, where you can have antidepressant synaptoplasticity without the head twitch? Can that happen? And it's still an agonist?
Absolutely. And see, this is so true. For example, most of us, when we did our pharmacology training, when you have a ligand that binds to a receptor, it's an agonist. Well, it agonizes, it activates, and that then leads to signal transduction, and the rest is history. It was a very simple story. Well, it turns out the story's not that simple. It turns out that when a ligand or a pharmaceutical, which behaves like a ligand, an endogenous ligand, binds to that receptor, well, it turns out a couple of things could happen. And it's called biased agonism. In other words, it turns out that there's different intracellular pathways. So it's a bit like when you walk into a building, that revolving door on the main, and there's the concierge standing there. You can turn left to go to the restaurant, turn right to the front desk, and check into your hotel, go up to your room. These are very different outcomes. Going for dinner, checking into your room. So this is a very different left and right. And that's biased. So once you get inside that cell, it's turn left or turn right. It turns out that some 5-HT2A agonists, when you bind to that receptor, you turn left. And you turn left, that leads to a head twitch in a rat, and that leads to psychedelic trips in people. You turn right, there's no head twitch going on, and doesn't seem to be, we don't think, the same degree of psychedelic activity. For example, we already have other drugs in medicine that are 5-HT2 agonists. They're better known in neurology. And these drugs don't cause people to trip. And it turns out those drugs go down the other. They turn right when you walk in the front door of the hotel. So they're not causing that. So 5-HT2A agonism is the revolving door on the main floor of that hotel, that building you walk in. But then, whether you turn left to the restaurant or turn right to check into the hotel, it's a very different outcome.
Well, can I also add here, there's a drug called xanomeline, which is actually a famous drug now because it's been filed for schizophrenia and celebrated as a muscarinic 1 and muscarinic 4 agonist. But I've got news for you. It is in the serotonin revolving door.
Yeah, that's true.
But it doesn't go anywhere. It just stays in there. So this drug binds to 5-HT2A and other subsets of receptors, but doesn't activate any of them. So that doesn't make a decision. So you can even have drugs that are agonists that don't trigger any signal transduction. You never get to your room or dinner.
Well, guys, I'm going to throw another wrench in this. There's also partial allosteric modulation. Oh my God. So there's another way of, if you will, stimulating without, being an endogenous ligand or binding to the orthosteric site, but you can bind to an allosteric site that changes the configuration of the receptor. So that's something happening on the outside, if you will, and enhances the binding of the endogenous ligand, or it can be, as you said, inside, going down different roads, different signal transduction pathways. Boy, this is getting complicated, guys.
It is, and this is why I use the revolving door as the metaphor, because my whole world sort of turned upside down, because I always had this sort of notion that, 5-HT2A receptors are just docked on top of that cellular membrane, waiting for a serotonin molecule to come along. I had no idea they can become intracellular, and it gets complicated. And so, in other words, imagine that revolving door, the hotel, and the main entry it's going, and so it shows, and it goes around, goes back inside the cell, comes back out. This is something very different. And so not all 5-HT2A agonists are the same. And again, once they activate the receptor through the orthosteric site or the allosteric site, the orthosteric site I just call the main site, and the allosteric's kind of like that STP oil treatment, the one on the side. It's kind of helping the engine go. I sort of see, okay, goes inside, am I turning left to the restaurant to grab a bite, but turning right to go check in the hotel? And that's a metaphor for some go down this molecular and behavioral pathway, molecular cellular behavioral pathway of twitching. The rats start twitching, which we think it's a trip, it's starting to trip, but others don't do that. So it's a very, very interesting way. And many folks are now interested in pursuing, if 5-HT2A is so relevant to the antidepressant effect, it may or may not be, can I go down that other route, turn right and not twitch, not have a psychedelic effect? And as you guys know, this is interesting. This has introduced a new vocabulary for us, a psychoplastogen and a neuroplastogen. And so,
exactly.
And I know, Steve, you've written about that.
Yeah, well, the idea is that these are plastogens. Mm-hmm. It's no question that they can cause neuroplasticity, in terms of new synapses forming. Not so much a neurogenesis, which means brand new formation of new neurons, but connections, yes. And so, you have the ones that do that without causing a hallucination, and we have examples of that. You've got Auvelity, which is the dextromethorphan, doesn't seem to do that. S-methadone. Mm-hmm. These are NMDA antagonists that work at the similar site of ketamine, and yet they don't cause dissociation. Mm-hmm. And then you've got even to the extent that zuranolone, which is a drug that works on GABA receptors, is an antidepressant. There's some evidence for that. It doesn't seem to cause hallucinations either. Mm-hmm. So it's not even a necessary or sufficient property. And I want to throw one other thing into the mix. It's called partnering. We'll call it that. Mm-hmm. Mm-hmm. Heterodimerization.
Right.
So, in other words, maybe we're getting this, and if you've heard our talks on the trace amines, that's one of the first clinical examples of that phenomenon. What does that mean? It means that sometimes receptors bind to other receptors, and when that happens, things change. Mm-hmm. And so in the case of the 5-HT2A receptor, there's now work going on suggesting that if you have the certain type of agonist, it will then marry, date, caress, hug, bind, whatever you want to call it, another receptor, and maybe even the so-called TrkB receptor, which is the one that is for BDNF. Mm-hmm. So there's a lot of things that can happen. Why does one 5-HT2A receptor turn left? Why does one turn right? One does one heterodimerize? These are all unknown questions. But it does leave the possibility that you don't have to hallucinate in order to have a rapid-acting antidepressant effect.
Yeah, let's get back to that, guys. I feel like our field has been myopic around monoamines and serotonin in particular. So what we're saying is really going to challenge a little bit of dogma here and blow people's mind that it may be the way these drugs are working are not even through these serotonin receptors. And we haven't even talked about some of the other serotonin receptors these drugs bind to. And I know, Roger, you've written an article about the risks of 5-HT2B agonization, which some of these drugs do as far as valvular heart disease. So what else are they doing, Roger?
Well, that's a great point. I've always believed that, if you can't explain something on a bumper sticker, you probably don't know what you're talking about. So we always like a nice, simple story. It almost becomes a slogan. I love slogans. Slogans stick with me and helps me sort of remember certain things. But slogans don't tell the whole story. And I think we've learned, for example, we've learned in other, classes of pharmacologic agents that other activities matter. And a lot of this comes down to where the street light is shining. And many of our colleagues joining us know that, for example, SSRIs target the serotonin transporter, but they have effects on other systems as well. For example, they have effects on sigma-1 systems, which has now been a target of bupropion, dextromethorphan combination. I mean, my goodness, so this is an important other receptor. So other things are happening. So, but bringing this back to the serotonergic psychedelics, if we were to create a table, and many of these exist now in our literature, where you sort of juxtapose the different serotonergic psychedelics together, you rank order all their binding affinities. What you find, they have affinities for other serotonergic receptors. They have affinities for other systems as well, including other monoamines like dopamine, but also other neurotransmitters are, depending on which one we're talking about, are also affected, including glutamate. But coming back to the serotonergic system, and Andy, I remember you and I had a conversation about this not too long ago. You and I were talking about, viloxazine and its history as an antidepressant and how it became a treatment for ADHD non-stimulant. And you and I were talking about 5-HT2B on that day. Right. And I remember that wasn't too long ago. You and I were talking, had that conversation over lunch in a meeting in Texas. And it's interesting because we have many medications that are 5-HT2B agonists. And for those who are maybe a little less familiar, 5-HT2B agonism raises at least a yellow flag for us, maybe sometimes a red flag, but certainly a yellow flag, because when the 5-HT2B receptors were looked at, they were located in different parts of the brain and body, but they do populate the cardiac valve and the subvalvular apparatus. And there's been plenty of examples, of course, fenfluramine, everyone knows fenfluramine, there's ergotamines. There's other drugs that are known to have effects that are agonistic effects at 5-HT2B. Some might be saying, well, so what? Well, the so what is that it could lead to an increase in fibrosis, an increase in deposition of glycosaminose glycans. The short story is this can lead to a regurgitant valve. And that leads to, well, pulmonary hypertension. And many people have heard of this with, of course, fenfluramine. Now, again, one doesn't want to be alarmist. We're not trying to be alarmist. We have to be safe, and we have to know what the safety profile is. And we need to have a full cardiac characterization. The good news is, it doesn't seem like the serotonergic psychedelics prolong QT intervals or other electrocardiographic parameters. That's good. But on structure, I think this is still something we need to sort out. The FDA has come out with guidance on this, and their guidance in very clear language is people who have pulmonary hypertension or who have pre-established cardiac valvular disease should be excluded from serotonergic psychedelic studies until we have a better handle on what's going on here.
So I think it's entirely possible that the FDA will not approve any 5-HT2B agonist ever again. And that means that's why you hear about microdosing and limited dosing, because that's going to be the best you're going to get out of these older drugs that are, promiscuous at a lot of receptors. But I also will mention another wild card, which is that there are numerous drugs that are 5-HT2B antagonists.
Right.
We have no idea what that contributes to the price of bread. Well, in other words, does this make it work better or not? But so 2B is a bit of a, or not 2B. That's the question.
Well, the question here with these drugs, though, is, as you're saying, these drugs are agonists at 5-HT2B. To some degree, some more than others. And the question is, which is worse, episodically hitting that, or in microdosing, you're consistently hitting it a little more consistently? And I think we just don't know. But the interesting thing is that 5-HT2B antagonism, and this is part of our conversation, Roger, that's pretty well emerging as an antidepressant mechanism.
Correct.
Because it disinhibits serotonin release, amongst other things. It's very involved with serotonin neurotransmission.
Yeah, it so is. And we all know correctly.
I was just going to mention
very high affinity for for D3. Well, we don't, again, this is where kind of like, it's like playing on a basketball team with LeBron James. No one can name anybody on the team that LeBron James plays. And so, the D3 is the LeBron James, and everyone talks about that with kryptonite, but it's also 5-HT2B antagonist. But again, no one knows is on the roster when LeBron James
is
playing.
Viloxazine, the 5-HT2B antagonist. Well, it's good. It's interesting you mentioned that, because I sometimes think in terms of teamwork. I know you and I are big sports fans, and the fact is that probably the whole is greater than the sum of the parts. And we know the best sports teams are teams where there's excellent chemistry and things are in balance, and it's not just one star, driving the whole ship. So getting back to these agents, what has been found recently, and we've shared amongst the three of us, we have shared an article in particular from Finland that blew my mind, because it talks about direct effects at that TrkB receptor. So it turns out these psychedelics actually have very high affinity at the TrkB receptor. They act as positive allosteric modulators. So talk a little bit about what's going on there. And we're talking about neuroplasticity as the final common pathway.
Yeah, that's such an interesting finding. It was a very rigorous study you're making reference to, Andy. And there's been, as you know, there's been a lot of work to show, molecular and cellular studies to show that when you activate the TrkB system, that can lead to an increase in BDNF, consequently plasticity. And then that is in accordance with some of the behavioral changes in the animal that we think are obviously highly imperfect, but is a sort of an index of an antidepressant effect. And what's interesting is that with treatments like psilocybin, maybe even LSD, They may be activating the TrkB, BDNF system, which is, in quotes, the antidepressant brain plasticity system, independent of the 5-HT2A.
Exactly. Independent of serotonin. Exactly.
Yeah, absolutely. Absolutely. So again, I think that's important. It's always difficult to bridge the lab to the bedside, but that's important because that is a highly replicated model in a paradigm that's well, described and so on. So I think that, and people may say, well, how does this really affect the bigger picture? Well, it does, because there's there's many drugs that are so-called 5-HT2 agonists or potentially psychedelics. And this is critical because the decision to go forward in developing these needs to be informed by the science. And also, if it's the case that you don't need the 5-HT2A for the antidepressant effect, and instead the 5-HT2A receptor is only igniting a cascade of events that leads to trips that may or may not be relevant, for example, then let's just focus on where the action is. Willie Sutton, the bank robber, said, "I rob banks where the money is." I think we take the Willie Sutton approach. We just go where the money is, and that's how you do it.
Well, don't you think that some of this almost exaggerated, hyperbolic interest in psychedelics, some of it comes from, of course, all of the purulent facts of the abuse and trips, but don't you think some of this comes from the unmet need that our current therapies propose, sort of the inadequacy of our current psychiatric treatments for a whole host of our psychiatric disorders? And maybe that's why people are getting so excited. Here we have something that may work very fast and on a variety of our conditions.
I think you hit the nail on the head, right, with the way you prefaced that, Andy. Look, I think that when it comes to the unmet need, I think there is a huge unmet need. I think you hit it right on the head. And I think if the needs of our patients were more than adequately addressed, I don't think there'd be a vacuum to fill. And there is a vacuum. Yeah. There's a lot of discouragement and a lot of gaps in our knowledge. And it's a fact that many, if not most, people don't knock it out of the park with the first antidepressant or other psychotropic drug they take for whatever condition. So I think that's part of it. I think that there has been an unmet need. So the question then, I've always said to people, there's nothing wrong with being passionate. Yeah. There's nothing wrong with being hyped up, but that should be moderating. That shouldn't be mediating your behavior. In other words, it should be a background tailwind for you. But we've got to have cognition be the rudder here. We've got to think this through carefully, safety first, do adequate and well-controlled trials. And I think in some respects, the psychedelics, they're kind of cursed by their history because they were never really developed in a rigorous way. They were put on the back shelf for reasons everyone knows, because of rescheduling and all that kind of thing. And they were never subjected to the interrogation that any medication would be expected to be interrogated today.
Well, it's interesting. Stahl, Dodd, and Michael Burke, who probably won't be listening to this because they're Australian, and I are looking to put together a book called Repurposing Recreational Drugs.
Nice.
And I think that there are almost any recreational drug you can think of.
That's right.
Can be thought of in therapeutic ways as well.
Right.
Part of that is due to the fact of the unmet need, as Roger so elegantly said. But I think also there's a little bit of anger towards the pharmaceutical industry and towards psychiatrists.
That's right.
That are too, bound to tradition, and payers that have a system in place which excludes certain people from getting better because they don't have other options. So they jump to these. And although there's promise to that, I still think that the enthusiasm, like you say, is a tailwind, is a nice analogy, but you have to actually be blown towards a scientific proof that these things are safe and effective.
Yeah. I've always said the brain doesn't know the difference between legal and illegal. These are just chemicals that have effects in the brain. And of course, the classic psychedelics, LSD and psilocybin, both, by the way, discovered by Albert Hofmann, they were developed as therapeutic agents, not as recreational agents initially. So I think you're right that a whole stigma has built up around these, and a whole belief system that I alluded to at the beginning here. There are some people now who just have this almost fanatical religious belief in how these things work. And I think you're right, Roger, that we have not subjected them to rigorous scientific investigation, which is starting to happen now. And you mentioned the FDA's published guidelines on these things. But I think what is concerning is, first of all, this title is psychedelic assisted psychotherapy, as if it's the psychotherapy that's doing the heavy lifting, and the psychedelics are just helping that. I think you have been leading the forefront of turning that on its head a little bit, right? Yeah.
Well, and going back to your comment a moment ago, Andy, I certainly have never tried to be a polemicist or an iconoclast or someone who's just trying to sort of make noise in the back of the room just for noise sake. I think, look, we have seen, all three of us have seen medications that have ended up in the medication cemetery because they weren't developed properly. And for those who are less familiar, I mean, there's many medications that just weren't sort of developed with the adequate controls and so on that clearly had potential effects. It just didn't receive the adequate scientific rigor. And I think that it's in keeping with advocacy for people suffering from agonizing mental illness that we want to make sure we have safe and effective treatments that are adequately developed. And that means, the foundational constructs of development are no different than any other medication. And when it comes to the whole issue of the psychedelic assisted psychotherapy, that is actually a hypothesis. But that hypothesis has become de facto and de jure. It's become sort of just, as you said, sort of religious.
Fanatical belief.
I think it's a hypothesis. Now, what is not a hypothesis is, does protocolized psychotherapy help any patients with mental illness?
Of course.
It absolutely does. It is not a hypothesis that when you combine medications like antidepressants with CBT and depression, many patients do better than either modality. That's not a hypothesis. But that's what we're talking about. With the psychedelic assisted psychotherapy, has a implicated mechanistic direction that what really is occurring is that the psychedelic, through its pharmacodynamic effect, is creating a biological change in brain that is then setting the fertile ground for the psychotherapy in its active ingredients to go in and do the work. And again, that is an interesting paradigm. It has a tremendous face validity to it, and it's compelling, but it is a hypothesis. And the reality is we don't know if this is psychedelic assisted psychotherapy or whether this is psychotherapy / psychoeducation / support benefiting the psychedelic.
Assisted psychedelic, right? Exactly.
Yeah. Or whether this is a behavioral toxicity that you have to endure in order to get through to the other side with the neuroplasticity. Now, having said that, I'm a big champion of neuroplasticity, and that this a lot of these behavioral things are epiphenomenon that we would like to get rid of. Having said that, there's this very interesting thing which we've talked about before on a previous podcast, Andy, and that has to do with reconsolidation. Mm-hmm. There is an idea in animal models which I think has a lot of validity, which is that you have a memory, it gets stored. If it's a horrible memory like PTSD, it gets stored deep, deep, deep into that amygdala, never to come out. Except it does come out, which is that if you're thinking of your memory and you can reactivate it, it becomes what you call labile. Because what happens is that the brain has a way of having a memory, and then you actually can act on it. But you have to have that memory reactivated. You're thinking about it, and then you can modify it, change it, store it, and guess what? Eliminate it. And so if you don't reconsolidate, the original memory is consolidated, then you have the memory later many times, and you reconsolidate it, restore it. If you can disrupt the restoration and the refiling of that memory, maybe you don't have it. So it may be, and this is wild. Are you ready? I propose that it may be possible, if such a mechanism exists in humans, to forget your addiction, to forget your PTSD, to forget it. And so, I mean, so I don't want to throw it out the possibility that you could create some sort of open a window that something is happening during a drug-induced event, which could then be exploited, to actually cause some major changes therapeutically. We don't know any of that, but I think we have to have an open mind about that. Right now, though, I think that I'm more impressed in this particular instance of patients coming to me and saying, "Oh my God, I went to Brazil or Africa, and I had this incredible experience. It was the most amazing thing. I already talked to my dead mother, and she forgave me, and all this stuff. I'm better and better." And I say, "Well, what do you do in my office for treatment-resistant depression, then, sir?"
Exactly.
So they have this incredible experience, but the dots are not connected to actually cause the enduring changes in treatment-resistant depression. So I'm a little bit skeptical that those experiences, which are quite dramatic, obviously, clearly, whether those are the therapeutic ones.
Well, it does appear that there's some degree of enduring benefit, but the question is always how long. Of course, with ECT and with ketamine, that benefit may only last, weeks. With psychedelics, it might last months, but eventually it may wear off.
Right.
Okay, guys, I'm going to put you both on the spot.
That's right.
I'm going to put you both on the spot. I'm going to start with Roger. Actually, let me start with Steve, and then I'll go to Roger. Steve, is the psychedelic trip necessary for the therapeutic effects of psychedelics? You can't wiggle out, Steve.
No or hell no?
Oh, okay, all right. Roger, what do you think?
Yeah, I think that I'm going to land in Camp Stahl on this one. I think that's still a testable hypothesis. I haven't seen any evidence whatsoever that the psychedelic trip is relevant to the therapeutic outcome.
Well, I think what's happened is, you put your finger on this, Roger. I think that we're learning more and more. Our drugs do a lot more than we think they do. And you used the analogy of the guy looking for his keys in the middle of the night in the parking lot, right? Yeah. And let's say his car's over here, but he's searching way over on the other side of the parking lot. His friend says to him, "What are you doing over here? Your car's over there. Shouldn't your keys be near the car?" He goes, "Yeah, but the light's better over here under the street light." So we know, for instance, that our traditional reuptake inhibiting antidepressants are increasing monoamines, but guess what? They also, some of them you mentioned, can be sigma-1 agonists, which is emerging as an antidepressant mechanism. And Steve, I don't know if you know this. You may not remember it because you've written so much. You wrote an article a few years ago called The Sigma Enigma, talking about this. I realize, that you've written so much, it's hard to keep track. But and also, guess what? They also bind to the TrkB receptor we've been talking about. They may have direct neuroplastic effects, but they have very low affinity. So it could be they don't work as robustly or as quickly as the psychedelics, which have high affinity. So the fact that psychedelics may have more than one mechanism, and some of the mechanisms may be therapeutic and some may not. And Steve mentioned ketamine. We know that ketamine causes robust dissociation, but yet there are other drugs in development, and certainly dextromethorphan is one. This is a pharmacokinetic issue. If you bind the NMDA receptor too tightly, you get toxicity of dissociation. But if you bind just enough, you can still be an antidepressant. And so maybe here we just have assumed this trip is necessary because it comes along as part of the package of the other things that these drugs are doing. So I'm with you guys. I think that the trip may not be necessary. I do think, as you said, Roger, I think this is a very nuanced and balanced approach, that therapy may be very helpful in addition to whatever these drugs are doing on their own.
Sure.
But I was in Japan a month ago talking to some of our colleagues in Japan. They are deathly afraid of psychedelic trips. They don't like to lose control. This is partly an Asian cultural phenomenon. Sure. And so they're more likely to take a medicine if they don't have to have therapy and a psychedelic trip on top of it. So what if we have a menu of options where if you want to get the psychedelic trip and the associated therapy, great, but you can also get this class of medicines as a pure antidepressant that is having these neuroplastic effects and still be effective, and then your personality isn't wired to have the other part of it.
But, the issue I think we should bring up now, not only are agonists different than antagonists, as we've just talked, so are the way you give drugs, whether it's an agonist or an antagonist. So, for example, if you slam a drug and you get it completely receptor occupancy very quickly, and then you come off of it very quickly, that can be an entirely different effect than if you kind of slowly go up, because there's obviously hallucinogenic effects of ketamine, there's anesthetic effects, and there are dissociative effects, and then there are sub-dissociative, sub-anesthetic effects. And some of those are related not only to the plasma level, but to how rapidly and how long you stay there. I mean, after all, think about it. You've got diamphetamine, or methamphetamine, which if you slam it and smoke it and put it through the surface area of the lung and put a sledgehammer into the brain over 2 seconds, it causes a glorious output of dopamine and a horrible depression and all that. Same drug can be used in 6-year-olds for ADHD. but it doesn't do that because you're using much lower doses and has different mechanisms. So the DMTs, the psychedelics, the psilocybins, could be very much different depending on how we administer them.
That's true.
And so we have to be sensitive to that. And I think that what it's beginning to look like is that slamming these drugs into somebody is not a good idea. That maybe you get some of the better effects and you can dissociate some of the bad and the good effects by giving them slowly and more enduringly and for a little longer period of time.
Yeah, that's so well put. And, many of our colleagues joining us may be wondering, well, they've heard or maybe they've read or what have you that there is evidence that you need the psychedelic trip for it to work. And so are we just ideologues who have our own opinion?
Right.
How do put all this together? I think that the challenge that we have with the published and available literature that has looked at that is the issue of what's called blinding integrity. Yeah. In all these studies, more than 90% of people know with a very high level of confidence that they're on the treatment they're allocated to. So you have what's called expectancy effects and so on. And that's going to bias the outcome. So you don't know if that's the trip or that's just expectancy and bias. And this is not an academic point. This is very serious. I remember when ketamine first came into psychiatry as a treatment for depression, there was a view, which has now been provably untrue, that you needed to dissociate for ketamine or esketamine to work. That is proven to be untrue. Right. You don't need to do that. And an example which some colleagues have said may not necessarily be the same example, but I think there is some similarity in this next example I'm going to give. I remember when I was a medical student and I was starting in early residency in psychiatry, left medical school. So in other words, this wasn't a million years ago, although it was a long time ago. And I remember that on the ward, like it happened an hour ago, and some of the colleagues joining us will remember this. I was told to dose the antipsychotic in my patients to a dose they got EPS, they got akathisia. Yep. And that was actually, and I remember having discussions in the nursing rounds, we were talking about, the patient's not benefiting, they have schizophrenia. Oh, well, are they having any akathisia? No. Yeah. Okay, we'll push the dose up. Right. You had to push the dose up to get akathisia. And again, this wasn't like 1,000 years ago. And that was based on a very similar idea, in my view, where the thought was, okay, you needed a certain dopamine occupancy to be an antipsychotic, and that dopamine occupancy was overlapping with akathisia. So, that's going to be our phenomenologic characteristic that's going to guide our dosing. Right. Well, it turned out it's all wrong. It's incredibly wrong. So that left people with unnecessary drug-induced movement disorders and TD and so on. And the other part is too, you guys know this, is that the trip is a big part of the safety concern. It's a big part of the wraparound, the support, the expense, the access. This has huge implications. And finally, some people, it doesn't seem to be very common, but some people are susceptible to what's called HPPD, hallucinogen persisting perceptual disorder.
Flashbacks, that's for our audience.
Flashbacks, So if we don't need to have this, and that's good. And then one final point, I think people have made a good argument around the issue of just equity getting into these studies. Because now, people who've had predisposition to psychosis or mania are not allowed in because, well, if you get a trip, it's not good for your underlying mental illness. But if you don't need the trip, then they're being excluded unnecessarily.
And of course, the fact that the trip is really what led to these drugs being Schedule I to begin with. Now, I think, too, this is not merely an academic discussion we're having, guys, because as somebody who's been involved with drug development now for 30 years, it seems to me that if we can parse out these different mechanisms, it may lead to more sophisticated and targeted drug development where I can get what's now being developed are second-generation psychedelics that target these other mechanisms without causing the trip. So it could be this will lead to more sophisticated drug development with less toxicity.
Could be, but I also see there's a possibility that this bifurcates and you go down the direction of some sort of politically motivated legalization of these things, in which case they will be administered, like medical marijuana. You just will be able to get it.
I'll get it on
It'll go into the lore of clinical practice and of psychotherapeutic practice, and people will claim what they claim. It won't be FDA approved, and it will probably be in the area of anecdotes. And then the other one will be to say if there's any science at the residual, now that we're in of our podcast, if there's any science here that, we'll be able to actually dissociate the hallucinatory experience from the therapeutic experience and have drugs with safety and efficacy by FDA standards, and then that will go forward. I think Australia is already moving, even Oregon. There are places in this world where you can get these drugs.
That's right.
And you can take a mushroom, you can lick a toad, whatever you want to do to get your DMT. Yeah. And it's just legal. And so you go to a therapist with your toad and have a nice day. I don't know. But I mean, I'm being facetious. But, the issue is that it could get out of control very rapidly.
Yeah, you're talking about classic psychedelics. I'm talking about going beyond that. I'm talking about developing drugs that don't have those
Oh yeah, that's the other bifurcation. I think that the classical psychedelics.
Road,
yeah, exactly. I hope it doesn't bifurcate.
Right. Well, that's a good point. I mean, the genie's out of the bottle to some degree. Guys, I was I mentioned earlier before we started recording, I was at a meeting recently with some of our colleagues, and Alan Young was speaking about the history of psychedelics, and I didn't realize, I was wondering why these things were put on the shelf, Schedule 1, no legitimate scientific research. And all of a sudden, recently, they've started coming back in a big way. And apparently, a colleague of ours who's a bit on the stubborn side, David Nutt, almost single-handedly forced people to reevaluate and start being able to study these drugs again. So it is really fascinating how these things sort of ebb and flow with the political and other winds.
David is an amazing character. We should probably have him on a podcast.
We should.
He as you know, he was one of the government's top experts on marijuana.
That's right.
And he said more people died of horseback riding accidents than marijuana, and he got promptly fired by the Tories who didn't like that because they liked horseback riding and they didn't want anybody to say nasty about it. And they wanted to regulate marijuana. So he's sometimes on the wrong side of the politics, but he's the most provocative, smart guy ever.
That's right.
Yeah, but I think that, and I agree. I think that it would be great to have David come on, and we already have a history of success. Ketamine, of course, has also had a somewhat romantic history. But look, it's saved lives now, and people with depression, reduces suicide. Dextromethorphan still has, in some parts of the world, it's restricted out of concern about abuse liability and so on. Yet it is now a effective and safe antidepressant helping many people. So the message is, can we in fact develop these treatments using adequate, well-controlled studies, safety, and let's see if we can get the right dosing, the right intervals, the right patients, and let's see if they could work. So I think it's still a wide open conversation for serotonergic psychedelics. But the comment I made earlier, I just happen to really believe that we have to make sure this is guided by thoughtful drug development and not emotional or ideologic drug development.
Roger, it's very hard to top what you just said. I think you've just summed up really what we're trying to do here in a beautiful nutshell. Mm-hmm. And I think that while it's fun for us to sit here who are kind of psychopharm geeks to do mental self-gratification, there is another term, mental something else, that I'm not going to use. I'll say mental self-gratification here to talk about these receptors and these activities and all of this. But the bottom line is what you're alluding to is the proof. Oh, well, I should use our friend Les Citrom taught me that the original version of the saying was the proof is in the tasting of the pudding, not the proof is in the pudding. But ultimately, either these drugs are going to work or they're not. And then we're going to have to figure out how to employ them in our practices. And there may be certain logistical issues and regulatory issues, and we're going to have maybe certain trained people and monitor all these other things. But, isn't that the truth with esketamine, which now requires certain kinds of special considerations? So I think if a drug works, we're going to figure out how to use it. In the history of psychiatry, if nothing else, is we've used pretty toxic interventions. We've used some pretty dramatic things like ECT. But ultimately, if they work, they endure, and we'll figure out how to use them. And especially if they work differently, or if they work, as you said, on a different set of patients, more patients, or if they work on a different set of symptoms or a different kind of outcome, as we talked about, if they help people to feel differently, to feel more like themselves, to feel more engaged, then we got something. We got a tiger by the tail, I think.
Yeah, it's so well put, Andy. And I think that, as you said, I think that we're talking about subpopulations. I don't think these are going to be the penicillin for psychiatry. But look, nobody needs to be convinced that we have a large number of people who have difficult to treat mental illness, whether it be PTSD or depression, bipolar disorder, OCD, the list goes on and on. So we have a large number of people who are suffering. Unfortunately, the conventional approaches haven't helped. But those conventional approaches help other people, and we need options. And so I think we absolutely have to study this and look at this. And that's the promise, I think, of ecstasy, and which we didn't talk too much about, but also the promise, I think, of serotonergic psychedelics. They're really helping some of these more difficult to treat.
And guess what? This is nothing more than the history of psychopharmacology recapitulated, where a failed antihistamine became a great tranquilizer for schizophrenia.
That's right.
Where an anti-tuberculous drug worked for depression, and so forth and so on. So these anecdotal observations can really revolutionize our field. So we keep our minds open.
A drug that was developed to treat lumbar puncture headaches became an amphetamine to treat ADHD. That is the history of amphetamine, actually, too. So, guys, this has been great. I could continue this conversation. In some ways, guys, we've known each other 25 years or so. We've been having this conversation in some form or other for over 20 years. But we've run out of time for this one, and I think we need to give each other the commitment that we will continue this conversation. And hopefully our audience has got something out of it. If nothing else, we've talked about some really intriguing theories about what could be going on with these medicines, how they may work, various kinds of molecular bases, if you will. But, ultimately, the science hopefully will win out. And I think Roger's point is so well taken. We really need to take some of the emotion out of this. We can all have our opinions. That's fine. But we really need to expose these treatments to scientific rigor and figure out if they can help people how to do that. All right, guys, we're going to have to wrap up. So, Steve, I'm going to give you
great stuff.
Just a couple final thoughts, and then Roger, I want to come to you.
Well, I couldn't be more pleased. This is a real brain trust here on this call with Roger and you, Andy. And so I think we brought up a lot of interesting things. The audience should feel they're on the cutting edge because this is where psychiatry is today. So it's been a delightful time. Thank you very much.
Yeah. Roger?
Yeah, look, Andy, great. Obviously, this is always fun. Professionally, it's more secondary. Personally, this is always fun to be with both yourself and Steve. And it's invigorating. It's hopeful. And I think that, for me, how I see it is, I think that this new frontier, I think it is a new frontier. It is really exciting for patients. And I think that to the best we can, let's just shepherd this. Let's just shepherd this in a way that's careful, because if we do have a serotonergic psychedelic that is really going to help some patients, let's not spoil the broth. And let's do the best we can to shepherd it properly. And it's an exciting time, and I've learned in my career as an academic and as a clinician that we don't have a surplus of hope, and we need more hope. And I do think, in fact, these are it's a very hopeful new set of treatment considerations and developments. It's been fun to have this conversation.
Yeah, I agree. And I think for our audience, we realize that clinical care is difficult, and sometimes it can be quite frustrating. And I think one of the things about this science we've been talking about that's exciting for me, it's reinvigorated me. I mean, I sometimes joke, I feel like I'm falling in love with my wife again. I fell in love with psychopharmacology over 30 years ago, and I'm falling in love again as I'm learning now about these actions at TrkB receptors, for instance, and BDNF and neuroplasticity. Oh, my God. But it is really part of the excitement, I think, and part of the things that gives us hope as clinicians and some optimism maybe that we can have new treatments and we can help more people in better ways. So if nothing else, I hope this podcast has been somewhat uplifting and hopeful. So I want to thank everybody for listening to another edition of the Psychopharmastahlogy Podcast. And for more information about our various offerings at NEI, our educational and other events, you can go to our website, NEIglobal.com. Thanks so much. We've got a couple more podcasts in this series that we're really looking forward to. Thanks a lot, guys.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.